Thank you, Sherry. Well, guess what? I'm between you and a break, so kind of been watching. Why don't we all just stand up for a few minutes, because, or just not for a few minutes, just for a quick few seconds. Just stand up and stretch. And as Sherry said, I've been in the emergency medicine, well, she didn't say this, but I've been in emergency medicine for well over 20 years. When I got to 20 years, I stopped talking about it. But started way back when as a registration clerk before we had computers. So really, remember the old paper numbers, those of you who are my age? So anyway, we're going to go through this. We're going to talk about ancillary services. Now, there's a whole lot more to ancillary services, but I am going to focus primarily on lab and radiology. Let me figure, there we go. So from this, is there anybody here that has a responsibility for any ancillary department? No, that's too bad. Our CEO or C-level person should be, if they're still here, raising their hand. But we really did want to have this talk about how the impact of ancillary services impacts the emergency department. So I wanted to talk a little bit, and I wanted to also point out there's been a couple of themes today. And those themes, can anybody tell me what they are? Because I want you to keep those in mind as I talk. Communication, great. What was that? Time. Data. Data's been a big factor today. As Sherry is always saying, we love data. I love data. But it really wasn't until I became an ED director that I really understood the impact of data. So I want you to think about, and we say teamwork? Teamwork's the other one. So I want you to think about teamwork, data, and your throughput, and how does that involve each of your own individual ancillary services. And I want you to start thinking outside the box, as Sherry said earlier this morning. Thinking outside the box is going to be very important. So the impact of the patient care, and why is ancillary services important? First of all, it's the impact of the patient care experience. Can they not, your ancillary services in your emergency department, really impact that patient care experience? So we really need to think about that. The other thing that's very important, as we've heard from a lot of other speakers today, is the diagnostics. Are you getting the diagnostics done in a timely manner so you, as emergency room physicians, can make that decision of where they need to go in a timely manner? That is going to impact our finances in the future. So this is going to be very, very important. But I do want to point out that one process in and of itself is not going to fix the ED length of stay. So when you think about this, and another thing that's come out today, if you haven't picked up on it, is design. When you look at your ancillary services and how they provide support to your department, has it been designed? So I want you to think about that too. So are they designed to meet your volume? Are they designed to do your turnaround time? If you went to your radiology director or any of your ancillary directors, could they tell you what your ED throughput time is? Does anybody can say yes? Can you, as ED leadership, do you know what their turnaround time is? Okay, see a couple heads nodding. So that's great. That means you're moving along. The other thing is, are they aligning their resources to meet the demand? Not only the demand of your ED, but they need to understand your demand. Jim showed earlier that little curve, which is true. Are they adding their resources to meet that demand? But they also have to balance their resources. Radiology and lab still tends to stay very heavy in the morning. They drop off in the evening shift, and then little to nothing in the night shift. So you need to look at that. Again, what is your physical structure? There's some limitations there. So when you design any kind of process or improvement, you need to look at those physical structure limitations. And then the impact of the inpatient turnaround time. And just one of the biggest things that can impact the ED is your ancillary services. How are they impacting the inpatient length of time? And where are their priorities? We all know for lab, what is it in the morning? It's their 6 a.m. lab draws. All the resources go there. So you need to look at that. Is the physicians upstairs getting those resources in order for them to be able to get the patient out the door so you can bring in somebody new? So we really, when you look at this, there's 3 things that I look at. First and foremost, it's quality. Is the ancillary services providing quality in their turnaround time and in their own data that they have put together? Are they aligned? and what are their work practices. So we're going to talk a little bit about each of these in the different areas. The other thing to look at is what is your patient population? This is very, very important. Can you tell me as ED leadership, what is your 10 top diagnoses you treat in your ED? And then how does ancillary services impact those top 10? And have you improved your work processes in those departments along with your own in order to meet that? So you want to look at those. You want to look at your demographics. What is your admission rate? What is your payer mix? Okay, so let's talk about aligning our resources. So there is a demand for ancillary services from outside of the emergency department. Is that a surprise? Was to me, because the emergency department should be first and foremost. But how are they staffing to that? If they're still staffing to the old model, I would suggest taking this back. And there's a lot of literature out there. On the last, my last slide has some resources there that talks about some of these. So you need to go back and really look at the demand that they're doing. But it's also taking the data and saying, when are these being ordered? And what types being ordered? So they make sure they have the right type of tech there at the right time of day. Also then from the inpatient side, you know, we went a few years ago that it came the 11 o'clock discharge on the inpatient side. How many people have made that 11 o'clock time? No hands. But again, it's looking at that inpatient demand and how are they using that? Do they communicate with each other? And so there's a lot of things your ancillary departments have to look at in order to do that. We all heard about tests if you have any kind of bed huddle that you do hospital-wide, whereas maybe they're waiting for the PT assessment to be done. But somebody here didn't talk to somebody there, so guess what? That patient now is staying another 24 hours. So we need to look at that and how can that be aligned. Equipment. Do you have the right equipment in your department for the type of patients you see? Have you looked at that? Have you broken it down? I have a slide broken down here in a little bit from radiology. And have you really broken that down by your individual department to say, by using your data, this is the type of equipment we need from radiology, from lab? We talked about the inpatient. So do you have a functional service, or do you have services that need to be redesigned? Or you have a question. So one of the things in some of the literature that I have in the back of your, in the back of my presentation is, if you have a 2-hour length of stay or turnaround for all of your patients, and you have less than 18%, they pretty much are saying that's a functional system. But now, there may be some redesign either in one or more areas if your length of stay is over 3 hours, if you have a greater than 20% admission rate, and then also they want you to look, the resource is now saying, look at the distance. And a lot of times when we talk about designing ERs, you want to look at the distance to your ancillary services. And how are you getting the services to and from? Okay, somebody pointed out communication. You know, sometimes we can make changes that are very, very simple. How many of you communicate daily with radiology? One person, 2, 3. Okay, this can be one of the most simplest things that you can do. You can have at the beginning of the shift for radiology, because it has to be for radiology, because they still tend to have about 3 shifts a day, as opposed to 2 that we mainly see in the emergency department. And really the easiest thing, as Sherry said with communication earlier, is that face-to-face communication. Have the shift lead for radiology come to the emergency department. Talk to the physician in charge and the charge nurse. Just very quick little huddle, if you will. You know, what are we seeing in the emergency department? What are our barriers for radiology? You know, can that be something we can fix? The other thing could be, are there machines broken in radiology? How many times have you ordered CAT scan after CAT scan and the CAT scan machine's down and nobody's told you? This improves communication. One of the biggest things you can do, and it's very easy to implement. The other thing is, do they have a dedicated phone? Your shift lead, so that if the physician can just immediately call and say, hey, we seem to be having some kind of issue here, as opposed to having to go through, you know, the unit clerk to the clerk in the radiology who has to hunt down the lead. So ways to decrease and improve your communication. Resource alignment is still going to be the same thing. Dedicated staff to the emergency department, and I have a slide here coming up that will go over that a little bit more. Workflow standardization. How are we doing our workflow standardization in radiology? Have they done that? Does anybody know if your radiology department has looked at that? And then digital reads, do you have that available 24/7? Oral contrast, we're also going to talk about a little bit. So know your data. How many of you have an electronic system? I think the majority of people in the room. Is that the same electronic system that you have in radiology? Do you know, do you use their data metrics for throughput? Do you use your own electronic system metrics? Are they aligned? Is the definition the same? Those are things, when we talk about knowing your data, that's one of the most important things you can see. Because say that you're looking at your radiology from your own system, whether it's, we've heard a lot of Epic, so we're looking at the Epic ones. Does radiology have Epic? If they don't, are their metrics behind the scene of how where the data fields they're pulling that from the same as the data fields you're pulling it from? So it's, you need to understand that. And then look at it and say, okay, our demand supports to have these different things. Does it make sense to have these different things? You have to take time to look at your data. A lot of times I see when I work with physician and nurse leaders in the emergency department is they don't trust the data coming out of ancillary services. Do you have that problem in your own facility? Yep, yeah. So a lot of that, again, can be just not understanding what your data metrics are. You're looking at it this way, they're looking at it this way. So you're not doing apples to apples. So that might be one of the first things to look at. Then again, look at your equipment and say, do you need these ones that are above it for the dedicated rooms, CT, ultrasound, based upon your patient population that you're seeing? This is a graph from earlier when Jim told you to look at take these numbers out and put in your numbers. So I didn't put any numbers here. But what I want you to do is and if your radiology director is not providing this to you, this is something that you should be looking at least on an annual basis. Because you want to look and say, okay, these are where we're looking at. We're doing these number of routine exams. We're doing this many for ultrasound and the different types of ultrasound. And then also for your CAT scans, the different types of CAT scans you're doing. So you start to understand, do you need to realign your resources? Because it's not that you can't just do this once. As Suzanne said, we're managing our department. And guess what? Our department changes. And a lot of this is the demographics of what we're seeing is going to change over the next 3 to 5 years, probably pretty significant from where we're at today. So Nighthawk, I see a lot of people use Nighthawk or some sort of off-site radiology at night. You need to look at that. I have talked recently, probably in the last year, to some clients that are starting to look at the cost effectiveness of this. Because as technology is changing and the availability of the radiologist on your staff, and again, this all depends on what size of radiology staff you have, but now that they're able to look at that PACS image at home, can they do this at home? Very much like the telemedicine. This is something that they'll be looking at and who has that capability. Transport. And let's talk a little bit about radiology transport. Do you have dedicated radiology transport, whether it's in your department or radiology? Anyone? A few. Again, there'll be another slide here in a minute, but you really need to look at that dedicated transport, because one of the things we look at, and that is different from the dedicated radiology tech. If you're far away from radiology, and that radiology tech is the one running the patient back and forth, guess what? They then are not doing the radiology test. Whereas a dedicated transporter for higher volumes, for the higher volume bands, can then be moving them back and forth and can be taking somebody while they're picking up. But again, you have to look at practice and how is the different staff doing that? Is it your own staff doing it? And again, you have to look at what is the best use for this. And let's see. This is it. This is from a couple of benchmark alliances and from hospitals that were best practice. So the data that came in, they looked like best practices, went back then and asked some questions. So as you can see, if you're at a 20K visit ED, you should have 24 hours of tech coverage a day, dedicated tech coverage. If you're at 40, it's 36. And then if you're at 60, it's 48. So kind of what is it here? Every time you go a volume bandwidth, you're adding 12 hours of dedicated tech coverage. So you can go ahead and just add 12 hours onto this if you're at those higher volumes. It's not just adding them, though. You have to look at how are you using that dedicated person. Are you using it in the best way? Because in the end result, what we want to do is we want to get that test taken, and we want to get the result back to the physician so the physician can make a determination on the level of care. What are your metrics? So, order written to ordered entered. Guess what? We've done that. But what if you need to know, what does that mean? If you're still on a paper system, then you have to define what that means. If you're not on a paper system and you're electronic, you need to be part of telling them where to pull that metric from. How are they pulling that? You know, especially if you have to go from one IT system to another IT system because they're on a separate one. So when is that occurring? And then the order entry to transport. It's one of the ones to look at that's very hard to, though, I've seen to implement that. So again, tight processes in place for that to occur. Transport time to procedure start. That's one of the biggest things you can look at is if we're so far away, maybe you're going to be building a new ED. This might be one of the ones to say we need dedicated rooms because look at this time that we're spending transporting. And then start time to results available. Again, look at these. If you're doing well on a lot of these, then we need to look at maybe we need to measure something else. Workflow assessment, when did you last assess it? Were you part of that assessment with your radiology director? You should be. Are you partners? Do you see radiology as a partner with you? Do the medical director for radiology and the ED meet? Do the nurse director and radiology director meet? These are going to be very important to have. Are you using technology? Are we using technology to maximize our workforce? To be able to say we can do more with the staff we have by utilizing technology. Communication. This is another one of these easy fixes. If you have a tracker board in the emergency department, do they have a tracker board in radiology? You know, you can fix those tracker boards to say, okay, for radiology, for a CT of the head, this is what we want it to be. And then you know how in the ED it turns when your length of stay gets to a certain color? You can do the same thing in radiology. And you can maybe only do that for stats. Of course, for the ED, everything is stats. Then, you know, Sherry and I have had a few discussions about that, what stat is, you know, what stat is stat. So you have to work with radiology to do this. And then color code, I really recommend that. Phones again, guess what? As Sherry talked about earlier, Voicera, that's just not for nursing, but I would say probably 99% of the time when I go into a facility with Voicera, it's only used in the nursing department. But there are key roles that I've seen. I've seen one place in California that all of leadership had Voicera along with all of nursing and then key ancillary leadership like your shift supervisors. So again, look at that. These can be great ways to do it, but again, you have to talk about noise. Noise is one of the things, the ambient noise that Sherry talked about earlier. So there are some easy things to make sure that you're tying into radiology and working with them on. Oral contrast. This is probably one of the controversial things I see around the country. So and this is a whole lecture onto itself, so I'm not going to spend too much time on this, but there are studies now that show radiology length of stay doubles when oral contrast is used in the ED. So I recommend to you, this has to be a multidisciplinary team approach. You need to go out there and look at evidence-based studies on this and sit down and work. I would say medical director to radiology medical director, you guys get on the same page to start with, and then you put this out to the rest and you come up with it. But this is, again, something I think that we're going to see is going to have to change, and we've had a lot of resistance in healthcare about this. Okay, we're going to go into lab a little bit. I'm going to talk about point of care, stat labs, barcoding, the lab tech that's based in the ED, tube system, and how do you identify specimens. So the core lab. Core lab, everybody kind of has your core lab downstairs or wherever it is in the building, and we have to have that. The next thing is how do we communicate to lab? So let's look at that next step. How does that occur? Do you have a tube system? How many of you have a tube system? I think Sherry asked that. Quite a few. Is it a dedicated tube system that goes straight from the ED to the lab? Some, yes. I will tell you, I went to one place and did a throughput assessment, and guess where we found one of the biggest bottlenecks was it took 8 minutes from the time the ED staff put that in for it to get to the lab, because it went all through the building and things like that. So if you have a very large facility, that might be one of the places you look at, and then how can that be fixed? Because it's not something you always think about doing. And specimen identification. And we're going to have a slide on this in a minute, but that's one of the things from a patient safety thing that we really have to take seriously. You really need to know if you're having mislabeled specimens, how is it occurring and why is it occurring, and then what to do to fix that. And then the lab tracking system. The stat lab and point of care I'm going to talk about, those are things that you need to look at. Again, these are two very controversial areas. And you need to really, drill down to say, when do you need them? How many people have a stat lab by chance? Very many? Just very few. Probably, 2, 3 hands went up on that. Point of care testing, we'll talk a little bit about that. So lab communication. Again, I've seen this done where the lab and the ED talk face to face. It's amazing how barriers come down, because the more of you raised your hand on lab barriers than you did on radiology barriers. But have this conversation. Again, we talked about the tube system. And for the ED specimen, I've seen what's really worked really well on this is when you color code, either the bag or the labels. I will tell you, the bags stand out. When I've gone through and looked at lab throughput, I will tell you, facilities with much better times for ED turnaround on lab is really looking at that colored bag, because the bag stands out much more than a label that's put in a clear, depending on how that tube is sitting in the tube, you can't necessarily tell that. Another thing about data is the same thing for lab as it is for radiology. What are they measuring? Because almost always the lab electronic system is different than the operating system for the rest of the hospital. So what are you measuring and what are they measuring? You have to come together to make sure you're both measuring the same thing, because that's the only way you'll be able to make an impact. Tracking system, very much the same. I've seen this time and time again. I've seen some really ones that look at stat labs. Most of the time they're only dealing with the ED, but one of the things that really can help as we think about really continuum of care and how can you get your patients upstairs quicker is, are they looking at stat on the inpatient side too? Because if they're not, they may be holding up that ICU bed that could be that the doctor is waiting to downgrade that patient on. So you need to really think about that. And again, this is why you need to understand your length of stay, what is really holding it up, and have data to back this up. Your metrics, are they color-coded? Again, can they color-code it and tie it in to the EHR and the ED? What are you measuring? Please spend time on this, because I think this is the biggest level of frustration when you have a lab throughput issue. And have you ever gone to a meeting with senior management and you're there and they're there, and all of a sudden you're talking some way and they're talking one way and nobody trusts the other side? And so until you come together as leadership in lab and in the ED and really look at that, if you have that issue, you have to start to trust each other, and you have to start it at the leadership level, because your staff will never do that if you don't trust the data. You have to be able to explain that to them. But when are you doing it is, again, when is the order entered or written? And you have to define that. Because again, if you're still on a paper metric, and it's from the time that Dr. Welsh writes the order, or is it the time the unit clerk enters it? And there can be a big variation in those two times. So understand what that is and make sure that you have that understanding and the lab has that. And then order entry to the specimen received in the lab, and then then the time the results are received back to the physician. Barcoding. How many of you have done barcoding? Just a few. How many of you love it? How many of you know it's coming? And you're excited. Yay, come on. Guess what? The ED has more mislabeling occur in the ED than any other unit in the hospital. And there's a lot of reasons for that. I mean, it is a chaotic situation. I've done it myself. I've drawn the lab, put it on the bedside table, then something else comes in, I take it, and then somebody moves that because they want that bedside table. It's very, very easy to do. There's a study in the back, and I forget the hospital's name, but I think it was somewhere in Georgia, that actually went to barcoding. And for the last 2 years, when they wrote the article at least, they had zero mislabeling. I know if there's a nurse directors in there, you spend a lot of time explaining away those mislabeled specimens to risk management and all the things that takes your time to go backtrack on those. So make sure that you do this. This is probably one of the #1 patient safety things that you can do for in the emergency department. I know the staff is not excited about this. You need to teach them why it's important. And this article that was written that I put in there as a reference is actually a very good, from the nurse director's perspective of how they were able to implement this. The biggest thing is this has got to be implemented correctly. You have got to design your workflow practices around this. Because if you do not design it and take the time to design it, you will not get the results that you want. It improves your phlebotomy productivity. Physicians are just happy because they're getting their results in a timely manner and they don't have to wait for the patient to be redrawn. And again, we're not ordering wrong. From the diagnostics, we're not ordering wrong treatments for that patient. So that has to be the #1 reason to do this. Stat lab. Again, there's a lot of mixed research on this. I had been consulting since 2005. When I first started this was a really big deal. It has kind of ebbed down, and then every once in a while I'll see people that are really behind this. So I will say you have to look at this from an operational standpoint. You have to go through and look at your data. Is it feasible? Is it feasible for the type of patients you see? And you have to look at what is the, there's some limitations from staff. We all have limitations on staff anymore. And can you overcome those limitations and structural limitations? So you have to look at that. I've seen places that have given up a room, and in larger facilities, a lot of times that makes sense. But you have to go through this, and you have to have a multidisciplinary team. The physicians need to be involved in this, lab needs to be involved in this, and I'd have a phlebotomist involved in this also. Point of care testing. Point of care testing is kind of comes and goes. It does have to be designed. Again, this is where we go back to our data and you look at your data. What type of patients are you seeing? What type of point of care testing should you be doing? And where are you at with your current lab throughput for that particular lab test? And then is it built into your evidence-based order sets? So look at this, really spend time with a multidisciplinary team to go through that. I will tell you, as I've researched this, no system is the same. Some systems may work best for Hospital A that would not work for Hospital B. So look at that, do due diligence when you research these, and don't believe the sales rep, because they will tell you it will fix everything. The thing with point of care testing, I will tell you, is it is coming out there. I think you need, this is one of the things, think outside of the box, try to think down the road where we're at. And there's a lot of studies that are now showing that it's going to be really in community-based medicines that it's going to be looking at. So there's things you need to be thinking about, what can we do different in the emergency department. Other areas for you to consider that we didn't talk about is admitting, case management, security, pharmacy. Those are all areas that a lot of what we talked about in lab and radiology, you can take that same type of information and plug it in there if you think that you're having a problem. Putting it all together, you should be balancing your ancillary needs to meet your ED needs, but you have to understand they have other areas that they're being pulled from. Multidisciplinary approach. If you don't do this by multidisciplinary approach, this team approach, you will not be successful at this. And again, this is a little typo that I changed in there. I forgot the word not when I typed this. I don't know why, but it doesn't have to be complex or expensive. As Sherry said earlier, think outside the box. And I will tell you, if you take a multidisciplinary approach, you put people in there to do these processes, they will come up with some of the most amazing, easy things to fix. Provide appropriate resources that meet both the ED and inpatient demands. Know your patients, know your data, make sure your data is accurate. Redesign your workflows. in all your areas to maximize your operations. Again, it's about quality, resource alignment, and work practices. So there we go. Any questions? I have 1 minute and 6 seconds, Terry.